We inaugurated this series several years ago for people who arrived early. We thought that it might give various physicians an opportunity to interact with experts in the field, myself excluded, however. And I have with me Dr. John Leonard, a close colleague of mine who's really considered an international expert in lymphoma. And to his left is Dr. David Rudman, who is really probably the world's outstanding expert on certainly bone metabolism in multiple myeloma, if not in myeloma itself. And we'll be joined, hopefully, by one of my other colleagues, Rick Furman, who is well known in CLL research. And I want to keep this informal and allow you folks to ask questions. Most people are very shy and don't want to ask questions, and very often I'm left to pepper them with questions. But if you have problem cases, bring them up now, because this is the opportunity to really glean the best from the very best. So without further ado, we'll start the program. Does anyone here have any particular patient problems that they would like to discuss with us? Well, if not, I'm going to start off. It's always, everyone's very shy. Maybe later on you'll be less shy. I'm going to first ask Dr. Leonard, how do you treat mantle cell lymphoma in those patients who are transplant eligible and those who are not transplant eligible? It's been a dispute, and there are a lot of different ways to approach it. Let's see how John would approach it.
How much time do we have?
Whatever.
So mantle cell lymphoma is really, I think, a disease where there are a number of treatment choices, as you know. I think there is limited evidence that overall survival is different with one therapy versus another for the most part. I would say that many centers, many investigators, many physicians would look at the patient and say, is the patient a transplant candidate? It is clear that transplants improve progression-free survival. It is not clear, at least in my mind, that they improve overall survival. And so the choice really for an individual patient is, do they go through a more intensive regimen and have a longer remission, or a less intensive regimen and have a shorter remission, with survival being the same? And the pros and cons of that more and less intensive regimen and shorter remission may be debated. So, you know, in my mind, I think that a transplant is great if it cures you. It's great if it makes you live substantially longer. If it makes you live marginally longer, then it's really a matter of debate. And so we have tended, as you know, to be less aggressive about doing transplantation. And I would say that in that sort of setting, outside of a protocol, I would typically treat most patients, whether or not they're transplant eligible or not, with most likely bendamustine rituximab followed by rituximab maintenance. I think the upfront regimen choices include bendamustine rituximab, as I mentioned. R-CHOP is pretty much obsolete, I would say. There are randomized trials showing if you substitute in bortezomib in the R-CHOP regimen, that offers advantages over R-CHOP. But I think that BR is probably better tolerated than a bortezomib-containing R-CHOP type regimen. The same study with, or data with R-CHOP suggests that rituximab maintenance adds an overall survival benefit that's not been demonstrated thus far with a BR-based regimen. But I would say outside of a protocol, I think BR plus R maintenance is a very reasonable strategy. That's the ongoing intergroup trial as the control arm, which has 4 arms. One is BR followed by R maintenance, and then the other arms include bortezomib as part of the induction, or lenalidomide as part of the maintenance. And I think that's a very useful and important trial that we're also accruing to.
You know, Jonathan Friedberg and Noble Fowler reported adding Velcade to bendamustine and Rituxan and felt that there was some improvement in progression-free survival. Would you, and since Velcade has certainly been approved for the treatment of mantle cell, would you give Velcade with the BR induction?
Well, we were part of the Friedberg study. I think that bortezomib does add to the toxicity of the regimen. As I mentioned, that's an arm of the ongoing study. Outside of a protocol, I generally wouldn't do it, but we'll see what those data show from the ongoing trial.
And some people attribute some magic to cytosine arabinoside in the treatment of mantle cell. Would you use that at the end for consolidation?
I generally wouldn't if I wasn't doing a transplant. I think the data suggest higher MRD negativity rates and higher CR rates if you're doing a transplant. I think that has not yet been extrapolated well in a randomized way in the non-transplant setting.
So you wouldn't use the RSC?
I typically wouldn't, no.
Okay, and what about Rituxan maintenance? We'll get to you too. What about Rituxan maintenance?
Yeah, I would use rituximab maintenance based on the R-CHOP with or without rituximab maintenance data show an overall survival benefit, and I would extrapolate to BR.
Yes, your question.
Oh, great. Along this line of thinking, I was curious what your thoughts are looking at carfilzomib versus bortezomib, given it has potentially less toxicity. And
I think the data in mantle cell or in lymphoma in general are pretty limited thus far. So I think there are studies being looked at. Obviously, that's a much more relevant drug in myeloma right now and is obviously approved there. But outside of a study, I wouldn't use it in lymphoma at this point.
I might add that carfilzomib is not the innocuous drug that it's made out to be. We've actually encountered a fair amount of cardiopulmonary problems. David, what do you think?
I think, can you hear me? I'm soft-spoken. So.
Oh.
I'm from the South. What do you want?
Are you really?
Yeah. I speak slowly and softly. But
Pittsburgh is not the South, David.
Anyway.
Nor is Indiana. Go ahead.
Anyway, now carfilzomib has been really touted as the drug to use over bortezomib because of the decreased neuropathy. I think the cardiotoxicity, the pulmonary toxicity is becoming a little more evident with prolonged use of the drug. And most recently, a number of trials have been stopped until the consent forms can be changed to talk about more pulmonary problems that these patients are having. Congestive heart failure is another one that they're seeing. So I think you have to be very careful, especially in myeloma patients. A lot of them are elderly, and they already have underlying cardiovascular disease.
There's been some talk about when they initially started, they were worried about rapid tumor lysis, and they insisted on giving a lot of fluid, which may to some degree have contributed to that. Now I understand that they've reduced the amount of fluid. So how do you give your carfilzomib? Over what period generally?
I do the standard.
Just the standard dose. Are there any other questions concerning carfilzomib or myeloma? Then, yes, sir.
What is the role of the new drugs in lymphoma, like ibrutinib? Are they going to be moved up front? Or
Sure. So the role of new drugs in mantle cell lymphoma. So I think there are several new drugs in mantle cell lymphoma that have either been approved or may be approved in the near future. Time will tell. Certainly in the relapse setting, in addition to bortezomib, we have lenalidomide, which is approved, and ibrutinib, which is approved, both in the recurrent disease setting. There are data our group have looked at lenalidomide rituximab in the upfront setting. I think there are studies that are going to be or are looking at ibrutinib in a number of different settings, not only in combination with chemotherapy such as BR in the relapse setting, but ultimately in the upfront setting. So right now, I think those are being looked at in clinical trials. So they're approved in the relapse setting. I think clinical trials are looking at them in one form or another, either as part of the induction or as a maintenance in the upfront setting, as well as a relapse setting in combinations. The other drug that has a fair amount of activity in early stages is venetoclax, the BCL2 inhibitor, and that's a drug that seems to be largely being developed outside of mantle cell lymphoma, but has activity there as well. So, I think those will be looked at as part of upfront therapy. The challenge in mantle cell lymphoma and any incurable disease is, if you don't cure people, and if you don't extend overall survival, is progression-free survival a really valuable endpoint? And getting a transplant, which gives you a longer progression-free survival, but requires several weeks in the hospital and a lot of short-term toxicity, but is done, versus chronic toxicity of taking a drug like ibrutinib or lenalidomide or rituximab maintenance, which may be manageable, but for some people more significant. It's really a quality of life endpoint that is a key factor if you're not extending survival. And I think that ultimately those are really the endpoints, not PFS. I think in follicular lymphoma, one might argue in CLL, And in mantle cell, the PFS endpoint is really a debatable one, but I think that's going to be the endpoint for a number of these trials. And we're going to be left with deciding, is it worth using an expensive drug with some chronic nagging toxicities to keep someone in remission longer if they don't necessarily live longer? So I think that's a challenge for the field.
The other challenge, of course, is there's not a whole lot of mantle cell lymphoma around to really do those randomized studies. So you either have to do nationwide studies, as the Europeans are very facile at doing, or either you have to do it as an intergroup study. David, what do you use as your gold standard treatment for a patient who's not transplant eligible for multiple myeloma?
We use MPV.
I'm sorry?
MRD, I'm sorry, MRD.
MRD?
Yeah, we use it for both.
You're still
If
using
they're elderly, we use MRD Light.
melphalan? When you say
No,
RVD?
RVD. My brain is dead today.
Okay,
RVD.
that's all right. All right, so RVD is pretty much the standard therapy. There are some others, of course, that are probably of equal efficacy from the evolution trial. So you got a patient who's on RVD and develops, looks like resistance. Where do you go next?
Well, it depends we look at their karyotype in their fish studies. If they're really high risk, you're in trouble no matter what you do.
Right.
We usually try to put them on trial is what we do, and try to see if they get a novel agent they haven't seen before in combination with something else. There are patients who fail RVD who still respond to carfilzomib. They will respond to pomalidomide. Those trials have been done and shown that there's responses. Those responses are not very long-lived. If the patients are resistant to RVD up front, you have a lot of trouble.
I guess relapse is a little different than resistance, but usually these patients are pretty much maintained anyhow, so relapse would be almost tantamount to resistance. What do you do with your P53 patients? If you can't put them on study?
It depends how old they are. If they're eligible for transplant, we take them, we give them, we induce them with RVD or whatever you like, or Cyborg-D, whatever the local regimen is. Then we take them to transplant, then we give them 2 cycles of consolidation, then we put them on maintenance.
Yeah, what do you think there's a role for allogeneic transplant in these patients with P53? They do so poorly. And,
I think outside of study, we don't do allogeneic transplant with myeloma, and they do poorly with transplant, although we have some studies looking at how to ameliorate GVHD using other immunotherapies, which may or may not be successful, but we have a trial of that. And also, we have looked at cord blood transplant, because remember Hal Broxmeyer's.
Right, sure, Hal Broxmeyer's in Indiana, right.
So we do a lot of cord blood for refractory hematologic malignancies, and I'm not too impressed with most of those results. You can cure patients with allotransplant, but you kill a lot of them.
You kill a lot of them, yeah. It's still not ready for prime time, but I wonder whether the one place where we might really want to consider it is with the P53 abnormalities, because you really need P53 to have chemotherapy genuinely work, and regardless of the disease, whether it's CLL, AML, lung cancer, myeloma, you mentioned it, if you have a P53 abnormality, you're in big trouble.
You're in big trouble. But I think there may be other targets that are being examined, at least
Right.
preclinically, that are effective in P53 negative, or they're actually, most of them are haploinsufficient, they're not really negative.
Well, ibrutinib, the signaling inhibitors seem not to be impacted by P53, but of course that's partly related to the fact that the BCR is turned on more. Any experience with ibrutinib in myeloma?
Not personally. Most of the data has been in lymphoma rather than myeloma. There's been a trial, a small trial, but we have no experience with the drug, so I really can't comment. The thing that I think is important is that immunotherapies are really becoming much more, common and available for myeloma patients. Daratumumab and the anti-CD38 there's 2 different anti-CD38s. There's a number of other ones being developed. There's an anti-CD138 antibody being developed. CAR T cells have been used in myeloma. Got a single case report in the New England Journal. I thought that was pretty cool.
That's a start.
Yeah, but there was a Nature Medicine paper looking at CAR T cells in myeloma, and those look interesting. I think that something independent of the genetic changes in the cells has to be done because there's multiple clones already present, and you're just selecting for whatever the emerging clone is by treating the other clones.
Which antigen did they direct the CAR T against in the myeloma? Do you remember? Was it 19?
Yeah,
or was it
CD19 made absolutely no sense.
Well, 20 doesn't get, I don't know if most of you are familiar with this, but CD20 is usually not expressed very often on myeloma cells, with the exception of IgA myeloma,
Right.
the one with 11-14 translocations. But in general, it doesn't seem to work. Do you have any experience with 19 expression in myeloma?
They couldn't understand why it worked. They used their CD19 engineered CAR T cell, and they got the response. They don't know the mechanisms. Carl June was just at our place.
Really?
He got a large prize, the Watanabe Prize for research, and he discussed it at length about how they were surprised they got any response because they just had them on the shelf. They went ahead and made them and gave them to this patient. They had a complete response, and they don't understand the mechanism at all yet.
Well, we have a very expensive new drug, of course, for Hodgkin's disease. We actually have a second very expensive drug for Hodgkin's, but the one that's really on the market is Acedris, John. Other than in the transplant setting or getting a patient set for transplant, do you use Acedris in any other situation? That's brentuximab vedotin for the uninitiated, and it's a monoclonal antibody with a warhead, MMAE, directed at CD30.
Well, I would say that it is useful in the relapse setting, particularly after a transplant. My sense of it pre-transplant is that it's pretty limited, and we've been part of studies using it prior to transplant. I think when you look at it as a single agent, it only gets about a quarter of people into complete remission as a single agent, whether you give it by itself or if you give it prior to chemotherapy. So, for 75% of patients with relapsed disease, if you give it a second-line therapy, they're still going to need chemotherapy before they get to a stem cell transplant. So I don't think it's particularly useful as a second-line therapy. There are some data combining it with chemotherapy. We'll see how that pans out. I've been less impressed with the maintenance after transplant as well, because again, there's a progression-free survival benefit, but not an overall survival benefit. So to treat 100 patients with a drug for a year that has toxicities and cost, to delay the relapse for a minority of them, in my mind, does not add a tremendous amount of value. So, I think it's really, and in that setting, using it in people who've gotten it before their transplant is also somewhat debatable. So, in my mind, I think at this point, it's really most useful in those who relapse after an auto transplant. I think if the patient is trying to get to a transplant, you can try it, but it's probably not going to get them there. And we'll see what the randomized studies show that incorporated in the ABVD versus ABVD alone to see if it makes a difference there.
Yeah. If you look at the initial data for AVD plus brentuximab vedotin, at least the phase 2 data are extraordinarily impressive. And we do know that the rapid responders who get treated with Hodgkin's disease, whether you do a PET scan after 1 or 2 cycles, do better than those who are slow responders. So suppose you had a patient who has, let's say, stage 3 disease, and you do a PET scan after 1 or 2 cycles, and they still have disease. It's come down a little bit, but they're a slow responder, and they're gradually getting into remission, and they're at cycle 4. And you do another PET, and you still have some increase in the SUV, maybe 5 from 12. Would you be tempted to add Acedris at that point?
I probably wouldn't do it at the end of therapy. It's also been noted that the ABVD, when you add in the brentuximab to ABVD, that you get false positive PET scans as well. So Jeremy Abramson at Mass General presented a small series of using ABVD, substituting in brentuximab for bleomycin, and showed that there were a substantial number of false positives there. And I have a patient who was on the trial who had a minimally positive PET at the end and was very concerned, and we're just watching her at this point because, again, this false positive rate is substantial.
What I was trying to point out is it's a slow responder on ABVD alone without the Acedris. Would you be tempted to add it?
I wouldn't. I mean, I think we'll see what the randomized trial data show and go from there.
Okay. And David, one of the issues is how long and how much bisphosphonate to give myeloma patients. There's no set rule. It depends on whom you read. How do you do it? You're the expert. Pardon?
Depends if you read my article or someone else's. The data are, all the data are prior to the Myeloma 9 trial were based on clinical trials that treated patients no longer than 2 years.
2 years, right.
That was because of the design of the trial and the cost of the trial, and they defined an endpoint that was previously never talked about, skeletal-related events, which Novartis defined as a way to measure responses. But I think the important point to first remember is bisphosphonates have revolutionized myeloma bone disease. You and I can remember in the 80s, patients who only got methylprednisone, and they were the patients in the ward who got a new cast every 2 weeks, and they came in with new fractures and multiple fractures, so that over the course of their disease, myeloma patients were getting 60% of them were getting fractures. And that's devastating because 20% increased mortality with fractures. I think now patients are still presenting with fractures. 70% of myeloma patients still present with bone disease. 60% of them are their myeloma-defining event. Bone pain is the most common symptom. And if you treat patients, 20% of them will have fractures. And if you treat them, at least the retrospective data from Turpos's study of 400 patients treated with more modern therapy than the Mayo study that initially reported fracture incidence over time, found that there's only about 1.2% fracture at relapse. There's still 20% of patients who needed XRT. So that's the first issue. And the Myeloma 9 trial showed a survival benefit with zoledronic acid in patients who did not have detectable bone disease by X-ray. Right,
by X-ray skeletal surveys, you
Yeah,
got to have
well,
about 80%
yeah.
demineralized.
Yeah, and they got probably therapy that we would never use in the United States because of the restrictions in England for the use of lenalidomide at that time. So they got thalidomide as part of the regimen. Be that as it may, the current recommendations by most groups are 2 years of therapy, and if you're in complete remission,
That's monthly therapy for
right,
2
monthly,
years.
right,
Right.
either pamidronate or zoledronic acid. And then people would either stop and watch them, or some people will change the length of interval between treatment. The Myeloma 9 trial showed, and the breast cancer bone metastasis trials have shown continued benefit of administration of bisphosphonates when they were looked at every 3 months or 6 months, so that they showed continued benefit. The incidence of O&J was, I think, a major concern of everybody, and that's why the Mayo Clinic, when they first gave their recommendations to stop therapy at 2 years, it was based on the fear of O&J, because that's osteonecrosis of the jaw. But the incidence of that has really gone way down. I remember maybe 5 years ago, 10% of the patients got O&J. Now I almost never see O&J.
Why do you think that's so?
Good dental care. People are more alert. They get their teeth in good shape, and they also monitored patients more
carefully.
closely for O&J. I never knew a doctor looked in anyone's mouth very much, except to look for a lump in the gum or on a tongue. They never looked at anybody's teeth. It's just like the dentist didn't know how to listen to somebody's heart. But I think the awareness of it has made dramatic changes in it. So the question then is there any other way to get around just arbitrarily defining when to stop? Nuparaji has a trial that looks at bone resorption markers in patients who've already gotten a year of bisphosphonate and then are treated either monthly or treated based on when their CTX levels go,
Right.
NTX or CTX, I forget which one she's measuring. And the results of that trial still aren't reported. But bone resorption markers are not very sensitive and not a good way to follow it. So
what do you do?
I knew that was coming. So
These people want to know what you do.
my own practice is if they're in complete remission or in a very good partial remission after a year or two of therapy, it depends on the patients, and there's a lot of individualization of therapy. I continue bisphosphonates, but I start extending the interval. So long as if they relapse, they get that or they get denosumab. But now the denosumab trial versus zoledronic acid trial will be finished next spring. They have 87% accrual already.
I think they're just about ready to close it, actually. That's
Are
what I
they not?
heard.
Do they have enough?
'Cause
I'm on
we're
the
doing it.
advisory board, but they had to get 600 events, and they lowered the number of events they
Right.
needed, and that's what was driving how
Well,
long.
did you think the denosumab, certainly the zoledronic acid sits in there for God knows how
Forever.
long, probably forever. What about with the denosumab? Do you have less ONJ? And
No, they had
do we
to s-
know? I know there's ONJ associated with it, but do they recover more quickly?
No.
Is there any advantage so far that you can see with denosumab?
Yeah, there's one advantage is that you can use it in renal failure. It doesn't matter because it's
Right.
a monoclonal antibody, but it's equally efficacious if you look at the initial trial, but that was done on such a small number of patients with myeloma, and they weren't appropriately stratified for disease progression or high risk, low risk renal failure or anything. So I think they're probably equally efficacious at the doses that they're using. I think that they make it more hypocalcemia. It's really very potent. You have to be very careful. I've had a couple patients who dropped their calcium within a week of getting a dose of denosumab, and it gets down to 7 or 6.5, and you have to really get even though they're vitamin D replete.
Okay. And then there's two other conundrums. The other one is you have a patient who has normal bone density and has got smoldering myeloma, or maybe MGUS bordering on smoldering myeloma. Do you give them bisphosphonate?
If they have normal bone density, I don't.
And if you got someone in MRD negative myeloma, do you give them bisphosphonate?
If they're already on it,
Let's say they're on it. Would you stop?
it depends how long they've been they've gotten to their lowest level of disease, their MRD. If they're just finished transplant and one or two cycles of RVD consolidation or are still on Rev maintenance, I'd probably continue it at least for a year or two to see what's going on.
So everybody, who's here used bisphosphonates in myeloma? Any of you? You do. So I guess what we've learned from Dr. Rudman, he gives it every month for 2 years and then spreads out the treatments. I've always been a little hesitant to do it, but maybe I'll rethink what I'm doing. Now, I'm going to hit John with a couple of hard ones. That was a tough one I asked Dr. Rudman. John, the hottest thing out now is double hit lymphomas or double expressing lymphomas. And the all of you know that large cell lymphoma, at least if you want to divide them on a basis of immunology, we have ABC and we have GCB, germinal center lymphomas, and we've got activated B-cell lymphoma. And the germinal centers, when you look for double hit, you look for expression by doing FISH, essentially, looking for MYC, which is always present, and also looking for BCL2 and BCL6. So we're going to start off, John, by asking, how do you treat a GCB double hit, genetically double hit, large cell lymphoma? What do you do? Do you still give them standard CHOP Rituxan, or are you into something else?
Well, I think the retrospective data, and we'll have a lecture on this at this meeting by Adam Petrick, who published the paper in Blood that retrospectively looked at a couple of hundred patients that were treated in different ways and basically suggested that our EPOC was the best approach and that stem cell transplant offered very little. So that's generally how I would treat
Yeah,
those
but
patients.
even the data for our EPOC is very wanting, but I do it, and I guess you do it as well. Do you think there's any merit in adding any other drugs?
For the
For
GCB
GCBs,
double
right.
hit by
Gene.
by FISH, at this point, no. I mean, we're planning a randomized trial where we're using venetoclax along with the chemotherapy in this setting. But and ultimately, we'll see what happens there. But at the present time, that's basically what I would do.
Now we got ABC lymphomas, and apparently to some degree they're a bit mutually exclusive. There's a difference between the FISH or genetic component to which we look for in GCB, but in ABC we look for expression, at least the end products. How do you treat your ABCs that may have double expression and therefore have poor prognosis. There's a little bit more play there. So what do you do?
So are you specifying that they have the double expression or not?
No, they do have the double. ABC without the double expression is
Right.
letting you get off too easy. So
Right.
we're going to give it
So-
a double expression.
Well, I think, at this point, the options are R-CHOP, R-EPOC, and then there are clinical trials using R-CHOP with ibrutinib or R-CHOP with lenalidomide. There are some more or less anecdotal data with R-EPOC with either lenalidomide or ibrutinib at this point. But, those are the options. I think if you ask people, if you ask 10 different lymphoma experts, you'll get about a third giving R-CHOP, a third giving R-EPOC, and then the others will toss in one of the new drugs. So.
Yep, we're waiting with bated breath for the results of the intergroup study looking at R-CHOP versus R-EPOC in large cell lymphoma. When is it coming out?
It should be sometime next year.
Sometime next year. Great. So would you like to comment on why they're using ibrutinib and why they're using Revlimid in the ABC lymphomas?
Well, there are pathways associated with the ABC subtype that are associated with B-cell receptor signaling, and there are data with ibrutinib in relapsed ABC subtype suggesting that there are responses in that subgroup. And more or less, the mechanism is less clear, but more or less the subtype specificity is similar, at least perhaps, with lenalidomide. So there are randomized trials looking at both of those based on those initial data, and time will tell. I think all those trials have a big challenge, and that is that there is a marked patient selection. And I'm going to talk a little bit about this, because the act or the process of seeing a patient and then centrally determining that they're ABC subtype results in patient selection that leads to a better outcome in the control group. And that may make those studies negative, even if the drug works in that subtype. So.
Yeah, Lou Stout, who really originally described ABC versus GCB by doing gene array analysis, has a program. He's getting into clinical medicine, and he's getting onto tenuous grounds, where he uses ibrutinib to knock out the BCR signaling, and the Revlimid to knock out the MID88 or MID88, however you want to call it. That's apparently very important also in the ABC lymphomas, and that's where the Revlimid comes into play. And of course, as everyone knows, Waldenstrom's is almost virtually, not always, but almost virtually characterized by overexpression of MID88. And of course, ibrutinib has just been approved for Waldenstrom's macroglobulinemia in the New England Journal. Dr. Rudman, what would you do for a patient who has, let's say, 20% plasma cells? And we do PET scans, and the PET scan shows no bone disease. There's no kidney disease. There's hematocrit of 35, okay? Kidney function is perfectly fine, so they have not really fulfilled the Crab criterion. But the light chain ratio is about 40 to 1. And the immunoglobulins are about 2.7 grams. What would you do with this patient? Would you prophylactically treat them? Would you watch them?
I'd
You would-
watch them. That's smoldering myeloma.
At what point would you say that a smoldering myeloma should be treated?
Well, there's now newer
Criterion, that's what I'm...
which changes things. I think the important thing to remember, when you do a marrow aspirate of biopsy on a patient, you're sampling a very small area. Myeloma is a spotty disease. It's not like acute leukemia where everything's... So if you do 2 or 3 biopsies over the course of a patient smoldering, you may get 20% one time, 15% another, 30% another. But I think the new criteria for defining myeloma, where you have greater than 60% plasma cells, or depending if you live in Spain, if you have more than 90 or 95% malignant plasma cells, and you have a free light chain
When I'm
ratio.
looking at a bone marrow, I can't tell you malignant from non-malignant, but anyhow.
They do it by flow. They do,
When I do it by flow, I'm
7
looking,
parameter,
they're looking
9
for
parameter,
monoclonality, yeah.
But So I think the current criteria that we use is a little simpler. It's greater than 60% plasma cells in your bone marrow and a free light chain ratio greater than 100.
100.
And that's important because you can get really confused if you're looking at labs from outside where the units they use for free light chains will drive you crazy. Some do it per liter, some do it per deciliter.
Right.
And you can have a patient in Florida relapse by reading the wrong.
Well, I look at the ratio
That's why it's very
that's-
important to look at that. But the involved light chain should be significant. It shouldn't be, it's so infinitesimally small, the denominator, that you can get a ratio over 100 when you have a very small amount of light chain and very little disease.
Let's say you have smoldering myeloma by all the criterion, including free light chains, but the person is putting out, let's say, 4 grams of kappa rather than lambda light chains, but the kidneys are still holding up. Would you consider that a criterion for?
I get very nervous.
So would I. That's why I'm
I would
asking.
I'd probably err on the side of treating that patient, even though people could criticize you for doing it, because myeloma survival in patients with renal failure is still significantly poor, and renal failure, significant renal failure, is a prognostic condition for poor outcome and for poor decreased survival.
Anybody have any questions for Dr. Rudman and his handling of myeloma and bone pains? Anybody? Any problematic patients? No? Everybody's quiet? Okay. Yes, sir.
Please comment. Thank you. What is the experience of bendamustine in both either Hodgkin's and myeloma?
In myeloma, there's been several trials. Suzanne Lynch, who'll be here
Right.
tomorrow, ran a bendamustine, lenalidomide, dexamethasone trial, and showed good activity in patients who had refractory myeloma, but the problem is they get very cytopenic and it's hard to keep them on the bendamustine. There's been also a trial using bendamustine, bortezomib, dexamethasone, and also showed activity. Most people in the myeloma field think of bendamustine as very expensive melphalan, but it's probably not true. That's probably
Well, some people, when they first came out with bendamustine, I said an alkylating agent is an alkylating agent. When bendamustine was approved, it was approved in CLL versus chlorambucil. And of course, bendamustine came out way on top. But when you look at the toxicity, you'd see that there was twice as much neutropenia and 3 times as much thrombocytopenia in the bendamustine arm than there was in chlorambucil. And actually, I was asked to give a talk at the FDA, and I kind of took them over the coals for approving on the basis of that study. There may be some magic to bendamustine. It has an alkylating arm, and it also has a purine arm. Whether that purine arm does anything, we really don't know. But one thing I do know is that giving it every 4 weeks can be very difficult. Now, there's a fellow by the name of Dr. Rummel, I'm sure Dr. Leonard could comment on it, who did the first study of BR versus CHOPR in low-grade lymphoma. I'm sure all of you are familiar with it, and showed a superiority of BR to CHOPR. Subsequent study didn't show any statistical response benefit, but toxicity seemed to be less. But in my own personal experience, when I give bendamustine every 4 cycles, I can't get in more than 4 cycles. You get a lot of neutropenia and thrombocytopenia. So what I usually wait is every 5 weeks, or when the counts come back to normal. I don't know what John does. I asked Dr. Rummel in his German study whether he was able to get in the medicine every 4 weeks for 6 cycles, and he said, "Jawohl, Dr. Coleman, we get it in, no problem." Well, I don't know. My patients maybe are a little bit different. John, what do you do when you use bendamustine? Do you give it every 4 weeks?
It depends. I think I usually do give it every 4 weeks, certainly in the upfront setting, and in younger patients. I think if the patient has renal insufficiency or is more heavily pretreated, then we tend to space it out a little bit more.
Right.
Can you comment on the use of bendamustine in Hodgkin's?
So it has activity in Hodgkin's. It's the data that are out there suggests it's about a 50-60% response rate as a single agent. It's relatively short, though, so it's kind of a palliative sort of thing. It's also been looked at as kind of getting patients to transplant. It's outpatient, so it's a reasonable thing to get people to transplant. There's Amyloid at Dana-Farber presented some data with bendamustine and brentuximab showing a very high response rate.
Yeah, it was about 90%.
Yeah, over 90% or so, although there was some toxicity with it. So, I think it's active, but it's really, it's not a curative therapy in Hodgkin's. So really either as palliation or as a way to get somebody to transplant.
Yeah, and we generally modify the dose. You can modify it one of two ways. You can give it less frequently, or you can drop the dose. And the elderly and the ones who are less fit, you might want to drop it to 70 or 60 milligrams per meter on days 1 and day 2. Are there any other questions with regard to? Yes, ma'am.
Could you comment on your thoughts for using lenalidomide in the first-line setting?
Oh, first-line setting of what?
Smoldering multiple myeloma patients.
Oh, okay. There's been a trial from Spain that looked at lenalidomide, dexamethasone, and what they defined as high-risk smoldering myeloma. And they showed very clearly there was a progression-free survival and an overall survival benefit treating those patients. That's the only trial I think that's been reported.
I think Raj Kumar did some work too, if I'm not mistaken, but it
but
wasn't a randomized study.
No, he just did a very small study, but this was a randomized study. And so patients who have high-risk myeloma, they fixed that problem. They now define them as active myeloma, essentially.
Well, I would say 90% plasma cells on a bone marrow gets you
Yeah.
pretty close to
Yeah.
to being as active as you want to be.
Greater than 60% is the one in the U.S. But yeah, I think if you have patients who you think are getting ready to rapidly progress, those are are going to be progressing within 2 years, I probably would go ahead and treat them.
All right, I'm gonna subject my colleagues up here to one more question apiece, and I'm gonna try to get some practical answers. Marginal zone lymphoma, there really isn't a whole lot of data out there, John. How do you treat marginal zone?
Well, it depends on the scenario.
Well, so I'm talking about disseminated nodal.
So disseminated
marginal zone.
nodal disease, I generally would treat with bendamustine, rituximab, or just single agent rituximab. It depends on the indication for therapy. More or less same thing with splenic marginal zone lymphoma, perhaps a little more prone to treat just with rituximab alone. In the relapse setting, there are data with both of those, either R alone or bendamustine, rituximab, or certainly there are data. There are data with lenalidomide. There are data with certainly idelalisib has activity there as well.
Yeah, and ibrutinib, actually, they may be getting approval very shortly on ibrutinib. And tell me how you approach your follicular lymphoma patients. Young man coming in, let's say 56 years old, got fair-sized nodes. Do you just give him BR? Do you try him with Rituxan? Do you consider radioimmunoconjugates? How do you approach your folliculars?
Well, I think the issue is, do they need therapy, yes or no, and then what therapy is it? And typically the therapies fall into three categories. Rituximab alone, bendamustine rituximab if they have more disease, need treatment a little bit more, and then if you're suspicious of transformation, I would generally use R-CHOP. We have randomized data coming along with lenalidomide rituximab, but outside of a study, I generally don't do that. I haven't included radioimmunotherapy as upfront therapy in a long time. As you know,
but
we did that
let's
as
say
well.
first relapse, would you consider using it?
Well, I think the first relapse data really come down to how long was the first remission. 20% of people progress within 2 years. That's a group of people that are not going to do well. So those are people that if they're young, I'm thinking about auto transplant before too long, depending on what their prior therapy was. I might be thinking about R-CHOP. If they've had a longer than 2 year remission, which is 80% of people, the data are that those are probably not people who are going to die of their disease, and you can do lots of different things. And since they had chemosensitive disease or treatment-sensitive disease, you have lots of options. I've not used radioimmunotherapy recently. I think we have better and less toxic options.
Well, if you look at the data for radioimmunotherapy, there's a plateau for these patients who go into CR. And it's about 20% of patients who never need to
Every
see
follicular
treatment.
lymphoma study has that same plateau.
Well, but
I
I'm
would
saying with
challenge
no
you.
recurrent disease.
Well, the bendamustine study, I have patients that got bendamustine on the pivotal trial, same 20% plateau,
Yeah, but
5, 6, 7, 8 years. I think that's something that you see in follicular
But
lymphoma.
they've actually seen this in patients with multiple recurrences, and which I don't think you'll see with chemotherapy. I think, and it's 2 weeks worth of therapy. It's a pity that the drugs are really not being used very much as a standalone. The reason they don't use it anymore is because when they gave CHOP Rituxan or whatever it was, and then gave the Bendamustine, they didn't see any benefit. But I wouldn't have expected under those circumstances at all. And I guess we're getting close, so we want to ask Dr. Rudman one last question. So you have a patient whom you've transplanted, got a nice response, and then relapses.
How far out?
He relapses, let's say, a year and a half out. What would you do with him?
That's an interesting question, because retreatment with transplant has been shown that if patients are, at least the studies, when they were at Andy Anderson, now he's at Memorial Sloan Kettering, was that it was greater than 18 months they would benefit from a second transplant. We have so many drugs in myeloma that I would probably hold transplant in abeyance and see if we could get a good remission and maintain the patient with maybe a couple of cycles of consolidation and then maintenance. I think the paradigm for treating myeloma is now it's almost continuous treatment. Though patients can't, people say that, but no one ever can do that because patients can't take Revlimid for more than about a year and a half or 2 years before cytopenias or other side effects, or they just won't take it anymore. They get tired of being tired. And a lot of them get diarrhea, which you can now treat a little better than we used to. But I think long-term treatment is probably going to be the standard of care. And it may be 4 agents, RVD or some combination of initials you like, but with a monoclonal antibody thrown in up front. And I think we're going to get, we're already getting like 80% CR VGPR rates with the drugs we have right now. And the data from the French Farber trial will be at ASH or ASCO. I heard they may have it at ASH.
Probably.
Yeah, and
Which brings up the next question, early versus late.
I think early is going to win.
You really think so?
Yeah, I haven't seen the data, but that would be my prejudice.
What we're talking about is you give a patient chemotherapy, harvest his bone marrow, his stem cells, and do you do the transplant then, or do you continue them on your successful therapy and only use the transplant when he relapses? You think early on is going to win?
I think it's going to win, though the data is that you're well aware that there's no survival benefit transplanting late versus early. Of course, the patient's got a lot of toxicity along the way. I think this study may be the way to define whether it's early versus late. I'm still a great advocate of autologous stem cell transplant. I think it gives you a really good, deep response, and patients get a much deeper response than what they had going in, and it can persist for a long time. 10 to 15% of myeloma patients are now living anywhere from 15 to 20 years, and the median survival of a standard risk myeloma patient is pushing 9 or 10 years.
Which is quite remarkable considering it used to be 2 to 3 years.
And they were miserable the whole 2 years before.
But with regard to your prediction of early versus late, I would write to remind you that most of the pundits said that Biden was going to run for president. And just one last question. Where do you see the monoclonal antibodies going? Do you think they're going to be used up front in combo, like CHOP-R?
Or like elotuzumab, Revlimid,
Right.
which looked really good as salvage. And I think they're all going to be used up front. I mean, that's what myeloma is a multi-clonal disease starting out, and you may be able to
get selection.
You may be able to avoid drug selection with throwing in an antibody as well.
Clonal selection.
Right.
One always worries about clonal selection versus the impact of the drugs you use in terms of creating more genetic abnormalities. Is the big debate. Did you have that P53 clone from the very outset? It just became more manifest as you knocked off the more sensitive cells. Are there any questions for either one of the panelists up here? Anybody? Yes, ma'am.
To what extent are you using nivolumab? Or what are your thoughts on nivolumab?
For what? For Hodgkin's or
For
what?
Hodgkin's, and I mean, it's investigational in other lymphomas. I'm just curious.
John?
Well, it's still investigational in Hodgkin's too. It's
Yeah.
being used in multiply relapsed patients here and there. I think it's active in other lymphomas. We'll see what happens with the clinical trials looking at it. So at this point, it's really just in Hodgkin's that's being used.
But my sense is, and again, I'm making a prediction, and you have to be very, very careful, as I was trying to tell Dr. Rudman. I have a feeling that Excedris and the checkpoint inhibitors are probably going to be incorporated up front sooner or later, and my sense is that they're going to make an impact for the simple reason that they operate by different mechanisms of action. I'm also wondering whether the use of Excedris up front for those patients with limited Hodgkin's disease in whom we now sometimes give radiation. There's a debate over if you have a negative PET scan, should you or should you not get radiation. That perhaps maybe one day that debate will be obviated by the use of Excedris or brentuximab vedotin. Whether that's going to really happen, or whether it's going to really prove true, I don't know. But I think there's a tendency, even in the solid tumors now, to get away from chemotherapy, or certainly to augment it with these new biologics. And we're just beginning to scratch the surface on their use, especially with the checkpoint inhibitors. There may be one disease that needs CTLA-4 inhibition, another one may need PD-L1, one may need PD-1. You just don't know yet. We're just scratching the surface and learning about these things. But it's a whole new brave world, frankly, in oncologic therapy now with these biologics of one fashion or another. And we haven't even touched on, of course, precision medicine, looking at the gene array and seeing which particular genes may be sensitive to direct therapy at that gene. Are there any other questions? If not, I've kind of beat up my panelists, and I want to thank them for really giving us some outstanding insights. Thank you very much.